Predictive Biomarkers for NET Treatment Response, Future Directions. Hello, this evidence-based content is prepared by Saboor, fellowship-trained consultant surgeon, and if you or someone you care about has been diagnosed with a neuroendocrine tumor, and you're wondering how doctors decide which treatment will actually work for you, you're in the right place. I know navigating treatment choices can feel overwhelming, especially when you're trying to understand why one person receives chemotherapy while another gets targeted therapy. Today we're going to explore the cutting-edge science of predictive biomarkers, essentially biological clues within your tumor that help guide which treatment will be most effective for you specifically. By the end, you'll understand how these biomarkers are transforming NET treatment from a one-size-fits-all approach to truly personalized medicine, and know exactly what questions to ask your oncologist about testing your tumor. Think of biomarkers as fingerprints within your tumor cells that reveal specific characteristics about how that tumor behaves, and, crucially, how it might respond to different treatments. Unlike general tumor markers like chromogranin A, which tells us that the tumor is present, predictive biomarkers tell us which specific therapy will likely work best. This matters enormously, because neuroendocrine tumors can vary dramatically from person to person. Choosing the wrong treatment first can delay effective control of your disease. Before we dive deeper into specific biomarkers, let's establish the key players transforming NET treatment selection today. These biomarkers provide the foundation for truly personalized treatment approaches that match therapy to your tumor's unique characteristics. Somatostatin receptor expression is perhaps the most established predictive biomarker for NETs, specifically for determining who will benefit from peptide receptor radionuclide therapy, PRRT. Based on the frequent expression of somatostatin receptors, particularly in well-differentiated neuroendocrine tumors, PRRT leverages these receptors as therapeutic targets. Your tumor cells may express proteins on their surface called somatostatin receptors, and PRRT works by attaching radioactive molecules to medications that specifically bind to these receptors, delivering radiation directly to tumor cells. But here's where it gets interesting. Not all NETs express these receptors equally. The evidence shows that adequate somatostatin receptor expression is essential for PRRT effectiveness. While most reports have focused on patients with lower-grade NETs, grades 1 and 2, there is emerging evidence that PRRT may also be effective in higher-grade tumors provided SSTR expression is adequate. The key clinical tool here is imaging with specialized scans like gallium-68 dotatate PET scans, which visualize how strongly your tumor expresses these receptors. If your tumor lights up brightly on these scans, you are more likely to benefit from PRRT. Ki-67 is a proliferation marker that measures how rapidly tumor cells are dividing, and it has become a critical decision point for chemotherapy. The Ki-67 index represents the percentage of cells actively dividing. Think of it as measuring how aggressively your tumor is behaving. Research indicates that Ki-67 predicts progression-free survival in well-differentiated neuroendocrine tumors, and specific thresholds guide treatment decisions. For pancreatic NETs, a Ki-67 value around 10% often represents a decision point. Evidence suggests that tumors with Ki-67 values below 10% may respond adequately to somatostatin analogs or targeted therapies, while those with higher values, particularly above 10 to 20%, may warrant more aggressive chemotherapy approaches. Recent data from the NETTER-2 study showed improved outcomes with PRRT as a type of targeted radiation therapy in advanced NETs with Ki-67 between 10 to 55%. What's particularly important for you to understand? Ki-67 can vary within different areas of the same tumor, a phenomenon called tumor heterogeneity. This means that getting adequate tissue sampling during biopsy is crucial for accurate Ki-67 assessment. MGMT, O6, methylguanine DNA methyltransferase, expression or methylation status may serve as a predictive marker for response to temozolomide-based chemotherapy, particularly in pancreatic NETs. MGMT is a DNA repair protein that can essentially fix the damage that temozolomide causes to tumor cells. When the MGMT gene is methylated, meaning it's turned off, the tumor cells can't repair the chemotherapy damage as effectively, making temozolomide more potent. Clinical trials are currently investigating whether testing for MGMT methylation can identify which patients will benefit most from temozolomide-capecitabine combinations. While research shows MGMT expression predicts response to temozolomide in pancreatic NETs, this testing isn't yet standard practice in daily clinical care. However, it represents an exciting frontier, particularly for situations where tumor reduction is the main therapeutic objective. The evidence shows response rates of approximately 36% in grade 3 gastroenteropancreatic neoplasms treated with temozolomide combinations, with responses favoring well-differentiated NETs and those with Ki-67 below 55%. Beyond these established biomarkers, translational studies are actively working to define biomarkers predicting response to targeted therapies and other chemotherapeutic strategies. The research reveals that increasing molecular evidence suggests grouping NETs according to mutational expression or methylation profiles, though therapeutic strategies based on these findings are still developing. New biomarkers under investigation include circulating tumor DNA and circulating mRNA, analyzed through tests like the NE test and tumor genomic profiling. DNA methylation patterns can identify subgroups of pancreatic NETs with specific clinical associations, and immune landscape profiling may reveal therapeutic potential in molecular subtypes. What this means for patients. Molecular profiling, when available, is encouraged to identify new therapeutic targets. However, outside specific biomarker contexts like mismatch repair deficiency or microsatellite instability, seen more in poorly differentiated carcinomas, many novel therapies remain investigational. Request a copy of your pathology report and identify which biomarkers have already been tested. Specifically, look for Ki-67% tumor grade and whether specialized imaging like gallium-68 dotatate PET has been performed. If you're considering treatment changes, ask whether your tumor tissue has been tested for MGMT status, particularly if temozolomide-based chemotherapy is being discussed. Verify that adequate tumor tissue is available for comprehensive testing. Come prepared with these specific questions. What is my tumor's Ki-67 index, and how does this influence which treatments we should consider first? Understanding your proliferation rate is fundamental to selecting appropriate therapy intensity. Has imaging demonstrated adequate somatostatin receptor expression to predict PRRT response? This question helps determine whether receptor-targeted therapy is appropriate for your specific tumor characteristics. If chemotherapy is being recommended, has MGMT methylation testing been done to guide drug selection? Are there clinical trials available that incorporate molecular profiling to identify targeted therapy options? Should my tumor be sent for comprehensive genomic testing to identify specific mutations that might be targetable? Seek specialized neuroendocrine tumor center consultation if your treatment isn't working as expected, if you're being offered treatments without clear biomarker guidance, or if your local oncologist hasn't discussed how your tumor's specific characteristics influence treatment selection. Management of NETs requires multidisciplinary approaches, and centers with adequate expertise routinely incorporate biomarker testing into treatment planning. Warning signs that warrant immediate discussion include rapid disease progression on current therapy, new or worsening symptoms despite treatment, or significant side effects limiting your quality of life. These situations may indicate the need for biomarker reassessment and treatment modification. Predictive biomarkers are transforming NET treatment from guesswork to precision medicine, with tools like somatostatin receptor imaging, Ki-67 thresholds, and MGMT methylation, helping select the right therapy for your specific tumor. Your next step is requesting a detailed discussion about which biomarkers have been tested in your case and how they are guiding treatment decisions. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here which you may find valuable for further information on predictive biomarkers in neuroendocrine tumors, including the European Neuroendocrine Tumor Society guidelines on standards of care, consensus statements on molecular imaging and theranostics, and pathology guidelines for diagnosis and prognostic stratification. Full links are in the description below.